invitation.
I think we are good to go
Yeah.
now.
Okay.
Okay. Okay. Shall we start?
Yes, please.
Yeah. Uh, Very good evening to all of you. I'm Dr. Arun Goyal. I'm Director Surgical Oncology at Max Super Specialty Hospital, Vaishali. And I'm also Executive Trustee of Indian Anti-Cancer Trust, the NGO on whose behalf we organize these events. So I believe many of you have attended events organized by us in the previous weeks. So we try to do an event every 2 weeks, focusing on one specific issue and just try to go a little deep into it. Majority of the events previously have been in the field of surgical oncology, but we had one on radiation oncology where we covered regional nodal irradiation. And for today's event, we have taken the topic of partial breast irradiation. So we hope to continue this activity for as long as we have good topics. The day we feel that we have exhausted the good topics, we will give a pause or a break. So with that, I would like to sort of hand over the mic to my colleague, Dr. Vaishali, to introduce the event further.
Yeah, thank you, Dr. Goel. Today we have the honor of having Dr. Jayant Vaidya, who has been the principal investigator in the famous targeted intraoperative radiotherapy, that is Target A trial, and he is going to present the long-term outcome results of this trial. And it will be followed by a lively discussion about partial breast irradiation, and I'm sure we are going to cover majority of the the problems or the issues we face in day-to-day lives when it comes to partial breast irradiation. We will take the question and answers at the end of the session. So I would request all the participants to keep their videos and audios on hold, keep the audios on mute, so that the quality of the presentation improves. And would request to write all your questions in the chat box so that we can take them at the end of the panel discussion. So would request now Dr. Arun Goyal to please introduce our orator, Dr. Vaidya, and then start the session.
Dr. Dinesh is my colleague, and since he represents the radiation oncology, so I would request Dr. Dinesh to do the honors. Dr. Dinesh, please.
Thank you, Dr. Goyal. In fact, it's an honor to have Professor Vaidya amongst us, and who is going to deliberate on his recent publications. Professor Vaidya is the Professor of Surgery and Oncology and Scientific Director, Surgical Interventional Trial Units in the University College of London, and he has been he's the principal investigator of the Target A trial. And I'm very eager to listen to you, Professor Vaidya. Kindly start.
Thank
And
you very much.
thanks for accepting our invitation to be the guest today.
Thank you very much. And it is a real pleasure to give this talk to everybody here with such eminent members. And let me start then. So this is the writing committee, Professor Tobias, Professor Balsara, and Professor Baum. And those are the authors. There are 39 authors in this paper, and it was published in the British Medical Journal just in the month of August, and it did receive a lot of media attention. This is the top is the International Steering Committee, and the bottom half shows this trial steering committee, independent steering committee appointed by the National Institute of Health Research, which governed the trial from the time of the last publication. I must not forget to thank and acknowledge every one of the investigator teams in these centers around the world and all the patients who participated in the trial. Without them, this trial couldn't have happened. And these are the photographs of all the authors. As you can see, they come from all over the world, and each of them has done a lot of work to make sure that we have this complete follow-up of this in this trial after such a long time. So the Target A trial asked a straightforward question: can risk-adapted single-dose target IORT given during lumpectomy for breast cancer effectively replace the usual postoperative course of daily radiotherapy, which normally goes on from 3 to 6 weeks? The recruitment of the trial started from March 2000 and ended in July 2012, over 12 years. A lot of the detail of the target trial and the details about literature, in fact, all of the literature is available on the website called target.org.uk. Sorry, this is the next slide is my conflict of interest is grant funding from NIHR-HTA, and I do receive some honoraria and travel reimbursement from Carl Zeiss. So you all will know how we have moved from radical surgery, in which people did, and some of us have done, this radical mastectomy, to more targeted surgery. And that has taken nearly 100 years for it to become standard of care between 1894, when William Halsted did the first demonstrated the safety of radical mastectomy. And over the last 25 years, we have moved from radical radiotherapy to more targeted radiotherapy. And that is a story I hope to tell you in this talk. And I go back to history, to Tata Memorial Hospital, and you can see here back in 1992, when I was a chief resident in Tata Hospital, I had to tell patients that you have breast cancer. And the next question I had to ask them was, can you stay in Bombay for 6 weeks of radiotherapy after the operation? And these were patients whose breasts could be preserved, but only if they said yes. If they said they cannot actually stay in Bombay, they have to go back to their home in North India or elsewhere, they had to have a mastectomy, because the package was lumpectomy plus whole breast radiotherapy. And this was a big concern. It was not a very nice thing to say to patients. But I thought this was only limited to India. It is not. When I started talking to people around the world, it happens in California, 3 miles from UCSF. My colleague, Dr. Michael Alvaro, tells me people don't want to cross the Bay Bridge when he sees them in the county hospital. This happens in Europe, in Australia, in Denmark. So people really don't like this traveling every day and repeated visits to the hospital. And this is even more important in the days of COVID. So this concern about breast cancer patients and the curiosity about breast cancer led me to do this whole organ analysis of mastectomy specimens. And that time, my mentor was Professor Dr. Neil Mitra. And what we found was quite unusual. We found that cancers were widespread all along the breast, all over the breast. And this was the first time we had done a 3-dimensional analysis. But this was at odds with where the local recurrence occurs. Now, local recurrence occurs mainly around the index quadrant. As you can see here, the red dots show the local recurrence events. If they occur in other parts of the breast, it also occurs at similar frequency in the other breast. So if you're not treating the other breast, why treat the whole breast? That was the question I asked when I presented this for the first time when I went abroad in Hong Kong in 1995. And the paper was published in 1996 in British Journal of Cancer. And then that's when I met Professor Michael Baum. And this is a letter we wrote together with Michael Baum and Dr. Neil Mitra to say that logical sequence of this study is we should do a clinical trial to test whether radiotherapy to the index quadrant alone can achieve good local control. Now, when I say we began pilot studies, that was because there was fortuitous meeting with the industry who were looking, who had this device which had not yet been used for breast cancer or cancer, and they needed it to be modified. So that is what happened between 1996, 1998 to 2000. We made a device in collaboration with industry to test this idea. So it was an idea, academic insight that led to the collaboration in industry to do a new treatment, new technique in order to test the approach, which was based on precision and immediacy of radiotherapy. So this is a photograph of a multidisciplinary team in 20 years ago, University College London. That is Professor Baum, that is Professor Tobias. You can see Dr. Neil Mitra here, and that is Professor Irving Taylor, you may have known. So the surgical technique, we described this in 2002. in European Journal of Surgical Oncology. It's a straightforward technique. This is a photograph taken on the first day we did this operation. This is the tumor bed, and that's a spherical applicator that goes inside the tumor bed. It is kept in place very securely and very accurately with a purse string, and that's Professor Baum and Professor Tobias. You can see in the photographs. So you can see the applicator going into the tumor bed, and 50 kV radiation is emitted from the tip of this tube, and a uniform dose of radiation is given around the spherical applicator. We can choose different sizes of applicators from 1.5 to 5 centimeters, depending on the tumor bed. So you can individualize the correct treatment on this. The radiotherapy is delivered immediately after lumpectomy under the same anesthetic. It is focused to the radiation around the tumor bed, and these are the tissues at highest risk of relapse. It therefore avoids normal structures from being irradiated, heart and the lungs. Again, the principle of precision and immediacy. The first 25 patients we did were using this as a boost because we wanted to be sure that it can be done. And we found it was safe to do it. It was possible to do it in a normal operation theater. It's important to remember that this does not require separate special operation theater. You don't need to have lead lining of any operation theater. Usual cement walls of an operation theater are enough. And radiation protection officers can check this for you in your operation theater. So it is something that is quite easy to adopt. Now, the most important question was, how does this compare with whole breast radiotherapy in terms of its efficacy and safety? And this was in the Target A trial. We gave the name of the procedure a name called Targeted Intraoperative Radiotherapy. The trial started in March 2000. So this is important to recognize that this trial was testing an approach of risk-adapted radiotherapy compared with standard radiotherapy, that is same radiotherapy for everybody. So it is not testing IORT versus EBRT, it's testing IORT for everybody with additional EBRT in some patients, about 20%. That is the whole approach that is being tested in the randomized trial. So if additional EBRT is added, it is not a trial violation, it is part of the protocol. And we expected that to be the case so that 8 out of 10 women will get away without needing any further radiotherapy. That was the ultimate aim. The second important point is that the age and the type of cancers were very broad. You have to be only more than or equal to 45 years of age with a single focus on clinical examination and routine imaging. MRI was not required. The tumor size was preferably less than 3.5 centimeters, and this was because the applicator size was 5 centimeters. So it is small, relatively small T2 tumors were completely acceptable. And what I understand is in India, the median tumor size is 3.5 centimeters. If that is the case, half the patients in India would be eligible for this treatment. So the first publication happened in July 2010, and the Lancet, when they published this in their paper, we were very surprised that they put our conclusion on the front page of the Lancet, saying that for selected patients, target IORT should be considered an alternative to whole breast radiotherapy. And that was now 10 years ago. In addition to this front page, they also had a comment by an independent person, Dr. David Azria. And what he said was this, that it is one method which is, he really quite praised it. And he said this now can be the new standard of care for selected patients. There are many obvious benefits of target IORT for breast cancer. Now they look obvious, but this is what we have found in proper studies. Cosmetic outcome is superior. This was found earlier in 2003. And then with objective assessment with Professor Mokeshkar, again, it was found to have superior cosmetic outcome. What happens is with target IORT, the cosmetic outcome remains constant all throughout. With EBRT, it goes down a bit. So statistically, it is stable in target IORT compared with EBRT. Quality of life is superior with target IORT, and this is found independently by 2 groups. One was in Australia and one was in Germany. So radiation-related quality of life was found to be superior. Cosmetic outcome, again, was found to be superior with target IORT. Another symptom which patients can have is pain. And in fact, the pain is not uncommon at all after normal surgery and radiotherapy. And we found that with IORT, the pain related to surgery This is a study from Copenhagen with Dr. Henrik Flieger, and this is again from Elena Sperk and Professor Wenz from Germany, showing that pain, breast symptoms, and arm symptoms are significantly reduced with target IORT. Now, this was a question about preference. And here we said, we assume that there is a 10% recurrence risk with target. Will you still prefer it? And these were studies in US and in America. And everywhere they found that the patients would prefer to have target IORT, and even doctors as patients. And that is the question asked by Tammy Corica in this paper. And doctors would still prefer to have target IORT. Whether it is cost saving or not, and this is really an important point. And this was a study in US, and in US, radiation therapy is extremely expensive. So this was a study by Michael Alvarado, who found that over 5 years, US would save $1.4 billion in the US if all suitable patients got IORT. Target IORT. I say target IORT because it should be differentiated from other types of IORT. This was a study from UK where about 9 million pounds would be saved per year. And this does not include the environmental and patient or societal costs. And I'll come to that in a second. And this is the environmental cost. You can see this study was done in the UK and in 2 centers in which we tried to map how much time the patient takes and how much travel the patient saves by taking target IORT. And it is not a simple journey. I mean, patients have to travel sometimes an hour, 2 hours, and this video is taken to go from a patient's own town to Oxford for taking their radiotherapy. And although it's safe, it's not a nice journey for patients to have. And you can see this map. Even in the UK, each of these dots represents a circle of 13 miles. So everybody in the green area has to travel more than 13 miles every day for taking their radiotherapy for many days. So we say, maybe jokingly, but in real terms, it does reduce carbon dioxide and it could reduce global warming, right? Another important point about target is that it improves tumor microenvironment. And this was a very surprising finding and done with a group in Italy where, and it is very scary for all of us surgeons, when we do an operation, the fluid that collects in the wound after the operation, if you take that and put it on breast cancer cell lines, this surgical fluid stimulates cancer cell proliferation, motility, and invasiveness. That's a scary thought. But the good news was that if you give on target IORT, this stimulatory effect of surgical wounding, which is probably very good for wound healing and has evolutionarily been sustained all this time, would be inhibited by getting target IORT. But it does not inhibit wound healing in terms of the skin. This is in the depth. Your skin doesn't get the radiation, so it heals well. In the depth of the wound where the fluid is, you find that the invasiveness is reduced, as you can see the central bar compared to the lateral bar, and the fluid cells moving are so much more in the top of this diagram compared to the lower half, which has received target IORT. So this is biologically suggests that target improves tumor microenvironment for the benefit of the patient. So we published the first 5-year results of local control and overall survival in 2013, November. And that is when a lot of centers around the world started using this technique. And now there are 260 centers around the world and about 45,000 patients have been treated. But breast cancer has a long natural history and long-term outcomes are therefore important. So we have been pursuing to get long-term data for this trial for the last 3 or 4 years. I mean, it has been going on for all these years, but it accelerated in the last 2-3 years. So the first patient was randomized in March 2000, and the long-term outcome data lock was on 3rd of July, 2019. For this, we kept the completeness of follow-up, we set the bar really high. What we said is that follow-up is to be considered complete only if 95% patients had at least 5-year complete follow-up. And at least 90% patients had either a 10-year follow-up or was seen within the previous year. So this was a very high bar and we achieved this bar. And to test that, regularly blinded data set was sent to the statistician to see if follow-up was complete or not. And only when the follow-up was complete, then was the time when the data was unblinded. And you can see one example of this
we
here.
have lost 2 patients. I'm so sorry about that. One has immigrated to Finland and one have immigrated to Bulgaria.
And this is out of how many patients?
It's out of 534 patients. We have lost 2, and I'm so sorry for that. I'm trying to get data on the lady who immigrated to Finland. I got a phone number, but she don't pick up the phone. But the one who immigrated to Bulgaria, I'm sorry to say, I think I lost her.
So this is Dr. Henrik Fleiger from Copenhagen, and this is the way we have tried to get the quest for complete follow-up. Teams all over the world helped to get this completeness to 95%, and the C2 team in UCL was really instrumental in making sure all this is properly entered, kept blinded, and then sent to the statistician only after the SAP, the statistical analysis plan, was signed off by the independent chair and another senior independent statistician, right? So the follow-up is now complete. So we can see here, the graph shows the actual and expected follow-up of patients in both arms of the trial. They're close to each other. So this is an extremely robust data set now. And comparing the amount of follow-up in all the other partial breast radiation trials for invasive breast cancer, you can see these skyscraper graph in which the left-hand most is target A. And each of these bars tells you the number of patients who have that many follow-ups. So red bar tells you that there are more than 2,000 patients with 5-year follow-up. And you can see here 1,000 patients have 9-year follow-up. And comparing that with other trials, this is the graph which is published in the British Medical Journal. So as I said, the unblinded data set was sent to the trial statistician in July 2019 after the SAP was signed by the chair of the independent TSC and the senior statistician, and Professor Balsara was the chief statistician of the trial. I want to remind you of the randomization. It is risk-adapted radiotherapy versus whole breast radiotherapy. First thing to check is whether randomization worked, and there was no difference in any of the patient and tumor characteristics in the 2 arms of the trial. And what is important here to recognize is that age and BMI, who are the very strong risk factors for causes from other deaths, other causes, were very similar in the 2 arms of the trial. So what are the advantages to the patient? Surgery and radiotherapy is completed at the same time. There is good cosmetic outcome. There is less pain. There are fewer complications. So they're all very good. But the patient is thinking this: what is my chance? I've had all these benefits. What is my chance of living without the cancer coming back? Is that as good? And this is the important point. These are the long-term outcomes now. Here we can see that local recurrence-free survival, the chance of a woman living without the cancer coming back in the breast, invasive cancer coming back in the breast, was no different between the 2 arms of the trial. At 5 years, it was 94.2% versus 94.2%. So no difference at all. Chance of living without having a mastectomy was exactly the same. And you can see that many times the curves for the target go slightly above, but there's no difference. Chance of a distant disease coming back and living without distant disease was exactly the same. Breast cancer specific survival was the same. And you can see this graph in a magnified view as published in the journal, in this graph, in which you can see the 2 lines for breast cancer mortality are on top of each other. And now comes the interesting point in this trial, is that the non-breast cancer mortality continued to separate from the time we saw it last time. And the line for target for overall survival always remained above that for EBRT. And these are the magnified graphs. You can see here that non-breast cancer mortality was significantly lower with target IORT, with a difference nearly halving from 9.85 to 5.41. And overall survival, again, there are separated lines, but because of the dilution with the breast cancer mortality, it is not statistically significant. So in 2000, the trial started. In 2010, we published the first results, and now we have published the long-term results, which show that breast cancer control is comparable to EBRT, and there is reduced non-breast cancer mortality with target IORT compared with EBRT. So these are the results in one slide, which show that similar local recurrence-free survival, the primary outcome, and non-breast cancer mortality, the target is better. And if you can see this in absolute terms, you can see that this is 9.85% versus 5.41, a difference of 4.4% at 12 years. Now, some facts here to set the record straight. And these are things that if you already read about this trial, I want to set these facts right. This is already there in the paper. Target A has the largest amount of follow-up data amongst PBI trials of invasive breast cancer. Fact number 2, it was not a low-risk population. There seems to be some concept that it is a low-risk population. It is not. There were nearly 2,000 patients who were all younger than 70 years. There were more than 400 patients in each of the high-risk groups of grade 3 cancers, positive nodes, and ER/PR nodes. So see that the node positivity rate is 22%. So that is not dissimilar from the 26% node positivity in most of the sentinel node biopsy projects. So really, these are not really low-risk patients. Sorry. This is the other fact 4. Target IORT is better than no radiotherapy. Now, there are randomized trials of no radiotherapy. They were all smaller than Target A trial. The CLGB, BASO2, and PRIME2 trials had very restrictive inclusion criteria. They had to be older patients. The tumor size had to be much smaller. The grade either had to be grade 1 or grade 1 or 2 with no LVI if they're grade 3. They all had to be node negative. Imagine that with a 22% node positivity in Target A trial. They had to have no lymphovascular invasion, and they had to be ER positive. And there were no such restrictions in Target A trial. And despite that, in the experimental arm in the Target A trial, the recurrence rate was 2 to 3 times lower than no radiotherapy. And this is important. Although you can't compare trials with trials, this is important to recognize that with Target IORT, there is local control. And this is at 5 years of absolute local control. In terms of local recurrence-free survival, it is no different. And in long term, no difference in local recurrence-free survival and fewer deaths from other causes. So in many ways, by getting Target, patients finishes the radiotherapy during the operation. It's like having nothing done. And 4 out of 5 times, they don't have to have any more radiotherapy. So it is as if they can have the cake and eat it too. Now, the next fact is that the reduced mortality in Target trial is actually consistent with other PBI trials. So we did this meta-analysis in 2016, published in the Red Journal, and then we published an update in the Lancet 2 years ago, including the import low trial, where it was very clear that with PBI versus WBI, the diamond for the difference was 0 for breast cancer deaths. There was a significant reduction in non-breast cancer deaths and a significant reduction in total deaths as well. So giving partial breast radiation seems to reduce overall mortality. And this is not completely implausible. EBRT is known to cause cardiac perfusion defects within 6 months, and this has been demonstrated long ago. And this is the reason why people are trying to reduce the dose by giving various breath holding techniques. But none of the breath holding techniques have actually been tested in randomized trials to be really effective or not. In smokers, radiotherapy causes a lot of side effects, and Caroline Taylor has shown how over the course of 30 years, there is a 6% increase in mortality from lung cancer and heart attacks among smokers. Now, giving external beam radiotherapy does not reduce mortality by 6%. So smokers should really not be given external beam radiotherapy when they have early breast cancer. The next fact is about other trials of NSABP. And I would like to propose that Target IORT is probably better than other methods of partial breast radiation. And I'm going to try and compare them with others. And the overall outcome that I would like to say is clearly for early breast cancer, partial breast radiation seems to be a better option than giving radiation to the whole breast. And we should remember that the recently pushed fast forward is actually whole breast radiotherapy, and it does have quite severe side effects. So we shouldn't substitute any other methods of partial breast radiation with 5 days of fast forward study. Now, looking at the NSABP trial, NSABP protocol requires 10 fractions given over 8 days, and every day you have to have 2 fractions. For the patient, the whole day is gone. and that's for 10 days, for 8 days at least. There is an additional procedure that's required for the balloon. There is always an inherent delay in starting radiotherapy. We don't have data for the balloon patients separately. And importantly, there is higher grade 2 and grade 3 toxicity. And that is not an unimportant amount. Secondly, 3D CRT and IMRT still leads to scatter radiation, and there is no reduction found in the trial in overall mortality. Rapid trial still requires 10 fractions over 5 to 8 days. Again, the whole day is gone for every one of these days. There is delay. There is increased grade 2 and grade 3 toxicity. Again, scatter radiation is still there with rapid trial. So both these seem to have a much higher grade 2 and grade 3 toxicity in the PBI arm compared to the WBI arm. And that is not something that is trivial. We published our data about delayed second procedure target IORT as well. Of course, it needs second procedure. Overall, it is not non-inferior, but if you restrict it to ER/PR positive and HER2 negative patients given endocrine therapy, it is indeed non-inferior. And this has been published in JAMA Oncology in the month of August. The local recurrence-free survival is not different from EBRT, and mastectomy-free survival is not different from EBRT. However, this is not our preferred method of giving target IORT at all. We believe it should be given during the lumpectomy procedure. Then comes the Elliott study. Elliott is the only other RCT of intraoperative radiotherapy. Their local recurrence rate at 5 years was 4.4 versus 0.4%, and we don't have long-term outcomes. We wonder whether the excessive tissue dissection that occurs and the tissue ischemia could be possibly the reason why their radiotherapy was not as effective. And there is much more shielding required in the operation theater because it's high energy. You can see what I mean by that. When target, that's the cavity, you put this applicator from within the breast and give the radiotherapy. Whereas with Elliott, you have to do a massive tissue dissection, bring the tissues central part of the breast together, and then give the radiotherapy by inserting a big spherical shield behind the breast. So there may be deoxygenation of tissues being irradiated compared to the fresh intact tumor bed with target IORT. But this is of course only a hypothesis. Next comes the Florence trial. It's really quite a small trial of 260 patients in each arm. There was better cosmetic and toxicity profile, but still it is 2 weeks of treatment, 5 non-consecutive days. And there are quite severe dose constraints from what I can see. You need to have 1 centimeter radius of the dose around the clips, and it should not be within 3 millimeters of the skin and not more than 4 millimeters from the lung. Imagine many patients with breast cancer with their breasts lying that way. If your tumor is close to skin, you can't use this treatment at all. And it is EBRT, it still gives rise to scatter radiation. The JAC-ESTRO trial has had excellent efficacy results. It has better toxicity profile, but it's still 8 fractions over the course of 4 days. And when we give patients a choice, we should show them photographs of what happens. And this is what happens when partial breast radiation is given using wires. Many of us feel this is not a particularly nice sight to show patients, but that doesn't mean they should not know how it happens. It also requires additional procedure. Import low trial, we don't have long-term data. And most importantly, it requires 3 weeks of daily radiotherapy, plus the visits for planning. And in terms of all that, reduction in dose, there should have been some improvement in toxicity profiles. It wasn't the case, really. In terms of prompts, there were 2 prompts in which there was improvement, and that was out of 72 different prompts being recorded. So target IORT, in terms of the Budapest trial, again uses wires. It is twice a day for 7 days, and there are again dose constraints, and it is a small trial of 130 versus 128 patients. So in conclusion, what I would like to say is risk-adapted target IORT given during lumpectomy achieved comparable long-term cancer control to EBRT. It reduced non-breast cancer mortality compared with EBRT. It has substantial advantages with better quality of life, cosmetically superior outcomes, less pain. Of course, it is much more convenient for the patient. And in 4 out of the 5 times, they don't have to have any more radiotherapy. It's all completed during the operation. There is less travel time. And importantly, there is lower cost to the patient and healthcare system. So we now, with these results, feel quite strongly that eligible patients should be offered target IORT as a one-stop treatment option during their lumpectomy for breast cancer. In the UK, the Montgomery ruling has said that if patients are not given all the reasonable alternatives, they should all be given reasonable alternatives, and that is the GMC guidance as well. And it is now the law that all patients should be given these alternatives, not just because of the preference of the treating team, but whatever the patient might want to know. So if you don't do this, they could be breaking the law. So now NICE gave approval recommendation for this to be used in centers that have the equipment in 2017. It has been adopted all around the world. So these are all international meetings. This is in 2016 user meeting. These have been going on for many years, but these are the recent photographs of 2016 Mannheim meeting in Germany. That is in Bangkok in 2016. And this was a meeting again in US, Mannheim. So overall, this is a center, this is a study which is being submitted for publication. There are 260 centers around the world in 38 countries who have offered target IORT to their patients. In India, it has been used in Hyderabad and by Dr. Vamsi and his team, and in Bombay by Dr. Sanjay Sharma. And all of those patients have been now counted. And each center has told me how many patients they have treated. And the total number is 44,500, plus I have to add another 250 to that. So it becomes nearly 45,000 have been treated with target IORT around the world. I believe it should be available to every suitable patient, and the technology is in fact less expensive than normal radiotherapy. So I hope this new publication makes it more easily available to people around the world. Thank you very much for your listening.
Thank you, Dr. Vaidya, for such a wonderful talk. Now we are going to have an interesting panel discussion, and I would request Dr. Vaidya also to stay on with us and be one of the panelists. I would like now to hand over to Dr. Arun Goyal and Dr. Dinesh Singh, who are going to moderate the panel discussion. And there are some questions for Dr. Vaidya, which probably will be addressing during the panel discussion, or maybe we'll take them at the end of the panel discussion. So over to you, Dr. Goyal and Dr. Dinesh, for the panel discussion.
Thank you, Dr. Vaishali. I would firstly like to invite the panelists or introduce the panelists. So we have Professor Punita Lal, who's at SGPGI Lucknow, an old friend from RCA James. Nice to have you, Dr. Punita, here.
Thank you so much. I'm so sorry to join in late.
No, it's all right. Nice. Dr. Haresh, Dr. KP Haresh, who's the additional professor in radiation oncology at IRCA James. We have Dr. Buddhi Yadav, who's the additional professor radiation oncology at PGI Chandigarh. Dr. Gautam Sharan, who's head of radiation oncology in Jawaharlal Nehru Cancer Hospital, Bhopal. And Dr. Vinita Goyal, who's head of radiation oncology at Max Hospital, Shalimar Bagh. So we have a panel which consists of 5 radiation oncologists, and Dr. Jayant is there to represent the interest of the surgeon also. And among the moderators, Dr. Dinesh is a radiation oncologist and I am a surgeon. So we have had a wonderful talk by Professor Vaidya, who's highlighted the journey and the benefits which are there. Since he has been involved with the target trial, so he is focused on the benefits which are definitely related to target and intrabeam specifically. But the issue which I would like to sort of bring forward is that this application of this approach requires installation of a new equipment. Now, in a country like India, where if we say the conventional radiotherapy facilities in itself, they cover maybe about less than 50% of the population have access to them. So adding a new equipment may be something which is not going to happen very soon or very fast. So definitely we have 2 installations in the country now, and over the coming years, we expect to see many more, but lot of other options are will be explored and used as considered feasible or optimal. So before we go further, I would like to have opinion from my panelists, maybe start with Dr. Punita Lal, is why APBI? So Dr. Vaidya has covered some benefits, which the question is whether all the benefits can be specific to target or any approach which is used for APBI. So Dr. Punita, why do you think APBI or a partial breast irradiation would be good for the patients?
Thank you, Dr. Arun. Sorry, I could not hear Dr. Vaidya's beautiful presentation. I was in the middle of another long standing, the meeting that we had earlier planned on. So yes, why APBI? Of course, it's a very pertinent question, but basically we have slowly moved based on the experience of the surgical people. We realized that the ipsilateral breast tumor recurrence rate is maximum in the quadrant or in and around the tumor bed region. So in a select group of patients which are low risk, there is a possibility that we can just get away by treating to the partial breast or the quadrant or that tumor bed with some safe margin, the partial the area around that. We need not maybe treating the whole breast in that select low risk group may be an overkill. That's the reason, the rationale behind a partial breast. And of course, because we are able to accelerate, it is so very much convenient to the patients. And what Dr. Vaidya would have told us was that in the same sitting, like the proponents of target have been doing that, it is so very convenient that in the same sitting you are done with both the surgery and the radiation portion. That's for the target. But in other methods also, you can very conveniently within a week's time get over with the irradiation component of the treatment, and that completes your treatment. Thank you.
Okay. Dr. Budhi, I would ask your comment here. We have hypofractionation as a very important component of whole breast radiation delivery. 15 days of radiation is being used for, say, now 3 years in our institute also, and Dr. Vinita might also be supporting that. And we now have publication of the fast forward trial and other data which shows that probably 1 week of external radiation to the whole breast would be a reasonable option. Now, do you say that the logistic advantage that we have in terms of, say, a reduced duration of treatment, is that taken away now?
I think still I would agree that hypofraction is one of the best way forward for breast cancer patients. We have been doing hypofraction since long in PGI, and now we do treatment in 2 weeks. We have moved from 3 weeks to 2 weeks. Okay. So I have completed a trial. Around 1,000 patients have been treated. So the data is now locked. So we are just looking forward for the follow of the patients. And I think that would not be the limit for hypofractionation. As fast forward has said that patient can be still treated with the 5 fractions or in a week. But there are certain limitations because in every center you cannot have 3D imaging facility and 3D planning. So at our center we do treat patients with 3D as well as 2D. So majority of the patients are treated with 2D, but we don't face any long-term toxicity that are quite high with the 2D as well, because it makes the planning very simple. We do APBI also. For APBI, we use 34 grain 10 fraction over 1 week. That our treatment is completed in 5 days. So like Dr. Jayant where they said it is in 5 to 8 days. But again, concern depend on the dose, how much you're delivering, because what I could see from other trial, the rapid trial and the NSABP trial, the doses where they have used for APBI, they have used a higher dose, like 38 gray in 10 fractions. That become a bit higher. We use 34 gray in 10 fractions, so we don't face much of toxicities, and local control rates are the same. We have published our data also on that. And we are also looking forward for 5-fraction regime. So we have started a protocol, but the limitation from the fast forward was it was majority of patients were early stage patients, and the patients which we get in our setup, they are locally advanced and high risk patients. So I think we need to do trials which suits for our patients. So that's what I think we should do. And the other thing is that we use exclusively EBRT for APBI, and we have also started another protocol of 3-fraction APBI with external beam radiotherapy.
Okay.
So because you are treating partial breast to long-term toxicity, and those to the heart or the lung may not be of that importance, because when you are treating partial breast, you won't throw much dose to these critical structures. But
Excellent,
again,
Dr.
we
Yadav.
look for the
Yeah,
long-term data.
yeah, I think so. Dr. Yadav, how much is the duration of that trial which you have follow-up duration? Because follow-up is very critical in breast cancer patients.
Yeah, in APBI trial, we had 5 years follow-up.
Okay.
So we have published that, but we couldn't get so much event because the patients were early stage. So we have just published the toxicity data in that. So I'm looking for the events for the local recurrence and other things. So still I'm following the patients.
Yeah,
And
looks very interesting. Yeah.
Yeah,
yeah.
this
So,
is
Dr.
very-
Vaidya, you want to make a
Vaidya-
comment?
Dr.
Yeah.
Vaidya wants to make a comment. Yeah.
2 or 3 comments. Well, that was very interesting to know this. These trials are randomized trials, are they?
Yeah, they are randomized trials.
Right. So I had not known about those. Are they published for the outcome measures already?
One of the
1,000
trial I have already
randomized trials?
published. APBI trial is already published, and the other one, the hypofractionation, we completed data last
Randomization
month only.
between WBI and APBI, was it?
Yeah,
So it is not one of the trials that I've listed. So I didn't know about it. Okay, that's excellent. I would like to read about it. The other point about fast forward is whole breast radiotherapy. It will irradiate heart and the lungs as usual. And
yeah.
what is missed out by people is that a quarter of patients, 1 in 4 patients, has got a hard indurated breast. That is what is reported by patients. And by physician assessed toxic side effects, the breast is indurated 19 times more often than external beam radiotherapy over longer fractions. So really, we don't want every 4th of our patient to get this hardened breast. And for what? And this, it's not 5 days. They have to go back for 1 more day for their planning, 1 more day for their consultation. And in a quarter of the patients, they have a boost. So it goes on to 15 days as well. So for COVID times, it has been pushed in some parts of the world, but that is really not a legitimate way. And they only have 5-year data, of course.
Yeah.
Whereas
So
the point I want to make is, we have now, irrespective of what is practically possible or not, if we had everything available, what to think of, this is here, these are the results. If you are starting new, would you want to have this? And when you look at the logistics of getting an equipment, in fact, I don't get any money when Zeiss sells any equipment, not at all. Well, if I did, I would be a millionaire. But what I mean is, it is not as expensive as normal radiotherapy. And in parts of the country where we don't have access to normal radiotherapy, it can be installed in the hospital. They can have a radiographer trained by the medical physics team, and it can be used. It has been done in the US, has been done in other parts of the world, where it can be given in a hospital where radiotherapy facility is not commonly available. So they can install the machine. It is really not very expensive. It is 300,000 pounds. So compared with what a Linac or so on costs, it is used for brain, it's used for bowel. And so I don't want to act like a salesman, but these are the results. As a doctor, if you want to give best to the patients, we should try and give what is the best. That's all I mean to say.
Can we have one comment from Dr. Sanjay Sharma? He is wanting to say something. Dr. Sanjay, please. You have to unmute yourself. Yeah.
Hi, Jayant. Nice
Hello.
talk. Thank you, see everybody. I wish I had done a randomized trial, but because premature, some logistic problems of keeping the machine in a hospital where there were no external radiation available. I totally agree with Jayant that this machine is on this kind of treatment is only suited for Indian villages, small places where external radiation therapy is not available. For logistic regions, cost regions, poverty, patients are not going to take radiation therapy and they are all mastectomized.
Okay.
In current era, if our early breast cancer and early ladies with reasonably good prognostic factors, I am 100% confident that we will be able to save at least about 50 to 60% breast, they are mastectomized. In my own series of 52 cases with now 9 years of follow-up, I returned to Jain then, only one girl who was very young and had a 4-year-old kid. She could not get the treatment for coming to hospital for 5 weeks because husband was a contractual worker. And I did an IORT and we put her on tamoxifen because she was very good risk. Unfortunately, we stopped the anti-hormones only in 5 years. I wish I had continued tamoxifen, she would have not regret. So it's a biology is the king or queen rather. If you choose your patient right, especially even in villages, you will be able to save 50 to 60% patient. And as Jan said, it costs nothing. Hello?
Yeah.
Can you hear me? I'm sorry, I lost.
We can still hear you. We can still hear you. Continue speaking, please.
Can hear you,
Hello?
Yeah, continue.
Continue speaking, please.
So what I'm trying to tell you that in India, we must collectively at small township where radiation therapy is not available, especially for younger patients even, because in my patients, I had patients more than 40 for 50% patients who Jayant included in target 2. So I have done that, and I'm pretty convinced in my mind that these kind of trials be done by radiation oncology with all kind of facilities not available at small towns. We'll do a lot of wonders, and we'll be able to give larger number of patients breast conservation. As Jayant said, in these patients, really external radiation therapy is not really necessary if the tumor is solitary.
Thank you, sir. Thank you, Dr. Sharma.
It was not a low-risk population. This is an important point, really. There were large number of patients with high risk. So it was not compared to other PBI trials and other even fast-forward trial. This is a trial which is suitable for people in India, for patients in India. That's what I feel. Okay. That's fine. I'll stop sharing. Yeah.
And Dr. Jayant, I see that in your paper you have included patients with node positivity also.
Yes.
You have 70 patients with 1 to 3 nodes and 3 patients with more than 3 nodes. So
Yes.
is there any subset analysis for that patients?
Yes, well, so 22% patients were node positive, and only a small fraction of those received whole breast radiotherapy as a supplement. So none of the local recurrences appeared in node positive patients. And we have done a subgroup analysis. It is currently under review. So I cannot give the answers, but it is good news. So I cannot give detailed answers to you just now, but it is currently under review, and it is pretty good news. So which is why I'm trying to say, if the patient is eligible for target A, they could have target A.
I think, Dr. Dinesh, we can go forward to the next question. Dr. Punita, you want to add something?
Maybe as we go along, I just wanted to say this, that yes, target is an attractive option, but for the garden variety, the kind of patients that we see with Dr. Sanjay Sharma alluded to the fact that mastectomy is higher. We see about still as of today, if you see about 60% of the patients are mastectomized. The biology that we see in our patients is more aggressive than what we would like to believe. We have 60% node positivity as against Dr. Vaidya's paper of 22%. Our tumors are larger, grade 3. If you look at Ashwini's paper on APBI, she has reported 82% grade 3s, which again is becoming a more important factor. Earlier grade was not considered in APBI, but now people are looking at that. Similarly, TNBCs are higher, patients are younger, ours are decade younger. So while an attractive option, but for a select group of patients is what I feel.
Completely agree with that, indeed. But the population of India is very large. So there will be a large number of patients who would fall into the group which would be eligible for target A. That's all I'm trying to say. I completely agree. We have to be selective and do it to the right patients.
Dr. Harish,
Dinesh, I think we can,
yeah, Dr. Harish, I would like to have your opinion that in your practice, what do you see, what percentage of population will be suitable for the APBI with whatever technique you want to give?
Yeah, the patient, right patient selection is the most important thing, because we see all groups of patients. So maybe around 5% patients will be fit for APBI, 5 to 10% patients, not more than that. But that 5%, 10% patients will be huge number, considering the huge load that we see in our day-to-day practice. We routinely do both interstitial, multi-catheter interstitial APBI and external beam APBI. That is what we do in our department routinely. But I stress that the right patient selection will be the more important when we go for APBI.
If I may say so, the patient's age, grade or tumor size or ER status didn't really make a difference in the outcomes. So what I'm trying to say is, where all other APBI trials had a super selective good risk patients, that was not the case with target A. And so it seems to work, which is what we had thought before, but we kept the criteria broad. So because maybe it's given at the right time. Maybe that's the reason. I don't know. But
I think size of the tumor was still kept to below 3.5 centimeters.
Yeah. But isn't the median tumor size in Tata Hospital 3.5? That means half the patients are under 3.5.
Well, India has got such a wide spectrum that we can't.
No, you can't say sure. And it is 25% in the UK. So if it is 10% in India, that is fine. But 25% of all patients, half of all breast conserving patients would be suitable. So that's not going to be the case. Yeah. Okay. Sorry. Please go ahead.
Dr. Vinita, what is your opinion about the selection of patients for APBI and the percentage you get at your institute?
So I am actually quite convinced about the use of partial breast radiation. And I would say that partial breast radiation has also evolved over last 20 years. It actually started, long back. The numbers have picked up in the recent times. But if we look at the older studies or older trials, then we have a sufficient follow-up of these patients to confidently use this technique in suitable patients. And I would also say that the criteria of selecting a suitable patients is also gradually getting expanded as we have more follow-up of these patients. For example, earlier we were restricting partial breast radiation only to tumors up to 2 centimeter. Now it is okay to use it up to 4 centimeter also. And as Dr. Vaidya also mentioned that earlier it was only, postmenopausal women, women who had ERPR positive tumors. Now it is being routinely used and indicated and has been found to be suitable and safe even for ERPR negative tumors. So I am quite convinced about the use of partial breast radiation, not in locally advanced breast cancer patients, not in patients who have N2 or N3 disease, but in a reasonably sized small tumor patients. The other thing is that I think there are several techniques of using partial breast radiation. And what is important is, although there are differences between single fraction target versus multi-fraction interstitial brachytherapy in terms of timing and resources, but rather than use whatever technique one can use safely, and there is no comparison of using brachytherapy or target versus any external beam radiation therapy, because with any kind of external beam radiation therapy, certainly a reasonable amount of dose goes to heart and the lungs, while in techniques like target or interstitial brachytherapy, one can substantially reduce these doses and are likely to impact the long-term non-cancer related mortality also in these patients. And as far as possible, if I have to use any kind of partial breast radiation, I would always prefer to do it intraoperatively rather than postoperatively or as a second procedure, because intraoperatively is the best chance to identify the tumor bed correctly. That's all from my side. Thank you.
Exactly.
Dr. Gautam, what are the absolute contraindications that you see in small tumors for partial breast irradiation?
So if we talk about the classic contraindication, you know, it started now these things that keeps on moving. Initially, well, I would say that it was an invasive lobular cancer, but now it's a cautionary one in the astro group. It's no more an absolute contraindication. But I think an absolute contraindication would be a multicentric disease. Multifocal would again not be a contraindication. Extensive nodal involvement, maybe N2 or N3. And a lady will, if I go by the published guidelines, females less than 40 years of age may not be a good candidate for APBI. Rest, as we have seen that the Astro has modified its recommendations in 2017. From there, they have reduced the age from 60 to 50, and then the cautionary group has come down to 40. So it's a continuously evolving process as the results are getting published. But I think multicentricity is an absolute contraindication. And yeah, yes, sir.
And what is your opinion about the tumor biology or the HER2 status or triple negative breast cancer?
Not a problem.
Okay, so an ideal candidate has to be an ER positive, but the guidelines do not speak about the HER2 status. But now even ER negative patients, provided they do not have any other unsuitable factors, may be taken up for APBI.
I would agree.
Dr. Dinesh, can I
sure.
intervene here?
Yeah.
See, what is being sort of projected here by the experts versus what is actually the written published guidelines available. So we have the ASTRO guideline, we have the NCCN document, we have, I think the most aggressive one probably, which includes the maximum eligibility criteria, is the Association of Breast Surgeons of America. Others are very, very conservative. In fact, recently we had a patient, a 73-year-old lady, T1CN0, and the final pathology showed a component of lobular carcinoma in situ. Now, based on the guidelines, she has been rejected for APBI. Maybe we can have comments from the experts.
Well, having lobular carcinoma in situ shouldn't really be a contraindication at all. In the trial, Target A trial, there were 60 patients who had lobular cancer, and none of the recurrences appeared in those. That number is really small. So we can't say that. There have been people who have been using it for small lobular cancers. We had excluded lobular cancers in the eligibility criteria, but in those days, these lobular cancers were extensive, infiltrating, occupying the whole quadrant.
Okay.
Nowadays, we have started getting lobular cancers, which are really tiny. And with MRI, they are very small. I personally don't see a reason not to use it. But of course, I can't say we have evidence for it. The only evidence we have is for those 60 patients when whom there was no difference, but no recurrence in any of them. And they didn't get more breast. Yeah.
So shall we say, but it's an era, let us say, when everything is guided by evidence. So would it be possible for you to put it in guidelines that a patient who's either ERPR positive or HER2 enriched or triple negative, and let us say T1 or T2 up to 4 centimeters N1A would be a candidate for APBI? Would you say that?
Well, I would say what I would say is what we will hopefully publish soon about our subgroup analysis, which on balance hasn't really found anything different. So that is what is going to come out in a more detail in publication. And if we find no difference in any subgroup, that means the Target A works in every subgroup of patients, then that is what the evidence should guide treatment. And we see what patients are in the trial, and we have seen, I've just shown what sort of patients are in the trial, what were the eligibility criteria. And that is what Target R is. Eligibility is same as Target A. I think that's similar to what American ABS is as well. Yeah.
Dr. Harish and Dr. Punita, can you comment about the eligibility, the wider eligibility criteria? Would you be comfortable with these?
Yeah, as of now, we are doing with 3 centimeter tumor upper limit, and age above 40 to 45 years of age, and unicentric disease, irrespective of lobular or IDC, whichever is it, and irrespective of LVSI or focal DCS. And we are all taking the patient for APBI. Even DCS also we are really doing APBI.
Yeah.
So the ERP renewal we are taking for APBI. We are not excluding any patients based on these things. Mainly margin-free resection, that is what we insist, and unicentric disease. And
you are taking node positive?
No. We are not doing node positive disease, node negative disease.
And Dr. Punita and Dr. Buddhi, one by one, maybe.
Yeah. So what I would say is that it is still probably wise to continue to be selective as the guidelines are advising us, because it's only about 5-6 years that we have moved APBI outside of clinical trial context into the routine practice. That's one point that I feel that needs to be factored in. About 2012 or 14, I think we were reading that it should be practiced in clinical trial setting. It's only after that we have moved out of it. Secondly, there are 3 areas that I would say that one needs to carve out for these kind of low risk or semi low risk people. One is the group that fits into the APBI group, which is like, okay, 45 to 50 and above, size criteria fulfilling, lymph node negative, ER positive, and so on and so forth. Then you move to the older subset of low risk category, where there are the PRIME trial and CalGB is working on telling us whether radiotherapy is really required or not also. So that's also that you need to factor in. The third thing is after the fast forward. Fast forward is again for select group, but it is more generalizable than the APBI. And just that I want to say that we are ourselves a part of one of the multicentric trials where, similar to fast forward, we have a 1 group versus 1 week versus 3 week trial that is running, and more generalizable to all our patients, including where there is RNI and all. So what I mean to say is that there is a group which is sitting on the fence for APBI versus whole breast, and probably they are the candidates to be taken in clinical trial setting today for looking at 1 week, looking at the, let me put it as limits of hypofractionation. So for whole breast, that's what I have to say.
Oh, can I just intervene
as
here?
far as I think carcinoma in situ is concerned, whether it is ductal carcinoma in situ or lobular carcinoma in situ, I think age is also one of the important factors, because elderly patients, you can treat ductal carcinoma in situ or lobular carcinoma with the partial breast irradiation.
Yes.
They may not recur during their lifetime, but if the patient is young, I think they should be excluded from APBI.
Okay.
The other thing I want to talk about, Dr. Jain said that in the fast forward, they treated the whole breast. If you see the majority of the patient in fast forward trial, they are eligible for, more than 75% of the patients, they are eligible for APBI. But they treated whole breast because they wanted to prove that hypofractionation is good enough for whole breast, comparing shorter duration and longer duration. So that was their point of view for the fast forward. But majority of their patients were suitable for APBI.
Now, as a surgeon, what I have observed is that whenever the axillary nodes are positive and the patient is receiving whole breast RT, the supraclavicular fossa is irradiated. So when we are talking of APBI, that field automatically goes out of consideration. So the question is APBI, then how does it become acceptable in a node positive patient? So maybe Dr. Harish and Dr. Vaidya, if you can.
We are not doing APBI in a node positive patient. Basically for the same reason, that because we have to irradiate the supraclavicular fossa. And I'll be more comfortable in taking in a node negative patient only, the patient for APBI.
So yes, that's an important point here. In the Target A trial, the standard treatment, if the node was positive, was to do an axillary clearance. And that's what has been done. If positive sentinel node is there, axillary clearance was done. There was no radiotherapy to the neck, and there was no increased recurrence in those patients in the neck. So regional recurrence rates were similar. So really, it didn't make a difference of not irradiating the neck or the axilla in patients who are node positive within the target recovery.
Okay.
Now, if you want to do Z11 type of protocol and you want to give radiotherapy to the whole breast and you want to be more cautious, then you may decide if there are more than 3 or 4 nodes involved that you want to add additional radiotherapy. Even if that is done, eight out of 10 patients will not need any further radiotherapy. That's how I would say. There are some questions on the chat. Do you want to take them now or when do we take them?
Yeah, I think we'll keep on involving them in between.
Okay.
Dr. Dinesh, do you want to take some of the questions now? Or?
Yeah, Dr. Vinita had asked, how about the use of target for an irregular surgical cavity and the largest sphere of cavity size that can be treated with target?
Well, the beauty of this is if you actually have seen a case or done a case, we were wondering about this when we started this process. We wondered what is the shape of the cavity. So I put this Cavicare material, which becomes a sponge and solidified within the cavity. It became like a very irregular shape. But that's not what happens when you actually put a sphere in it. When you put a sphere in it, breast is very malleable and soft. It actually goes around and wraps around the spherical applicator very nicely. So the cavity doesn't remain irregular anymore because it gets applied to the tumor, to the applicator very nicely inside the purse string. So it is really quite nice. It was a revealing for us when we did the first few cases. The biggest cavity size by definition is a 5 centimeter cavity. 5 centimeters is the largest applicator. But you find that sometimes when you have taken a tissue of about that size, the breast, if it is in older patients in the outer quadrant, it goes down that way. But you can pull the deep part together with the purse string. You can take the superficial part together with the purse string. And in most patients, I haven't found it possible. It's not been at all difficult to apply the tumor bed to the cavity, to the applicator surface. So it is, apart from very few patients in the lower inner quadrant, where there is no breast tissue at all left behind, that is the only time when it can be sometimes tricky. Because we want to keep a distance to the skin about 8 millimeters. So, and otherwise you have to deflect the skin off or take the skin away. It is surprisingly easy to be used in most patients.
Patricia is asking how much depth can be treated maximum.
So the depth is at 1 centimeter, the dose is 6 gray.
So is that sufficient 6 gray?
Well, that is, the proof of the pudding is in eating. We have tested it. That is the dose which was given. And the whole point, I think, is when we do wide local excision, we are extremely careful about our margins. We make sure that we get clear margins. We take X-ray of the specimen in the lab. We take, by final pathology, take the margin specimen. So we don't believe there are too many cells left behind, really. I think one of the major effects of this radiotherapy is in making sure that cancer cells circulating in the blood don't go there in that tumor bed, which is actively stimulating cancer cell proliferation and get local recurrence there. So that may be the cause of local recurrence more than the tumor cells left behind. That used to be the case long ago when margins were not so carefully looked after.
In fact, I'll ask the panel at this time, Dr. Goel, one minute. Yeah, one question I'll ask the panel. That are you all comfortable with a dose of 5 to 7 gray single fraction when it is being given? Because when we are treating with IMRT or with interstitial brachytherapy, we are going to a much higher dose with
20 gray to the surface, though.
1 to 2 centimeters.
It's 20 gray to the surface.
Okay. Yeah, gray to the surface and 6 gray.
But at 1 centimeter, it falls down to 5 to 7 gray.
Yes, indeed.
It's not.
Indeed.
I wouldn't be comfortable. Because
which is why we did the trial. The trials, it worked.
It works. It works. Finally, it works.
That's all matters. Yeah.
Let us say what are the other schedules, say with brachytherapy or with external RT. Maybe Dr. Haresh, you can talk about the external RT dose schedule.
Yeah, with external RT, what we are routinely giving is 38 gray in 10 fractions, 2 fractions per day. And with brachytherapy, our protocol is 35 gray, not a 34 standard. We give 35 gray in 10 fractions, 2 fractions per day. That's what we are doing with the brachytherapy. And with brachy, we do 2 different protocols. One is peroperative implant, when we put the brachytherapy catheters during the surgery. And the other thing is ultrasound guided insertion post surgery, maybe one month after surgery. These 2 protocols that we're following routinely.
There is one important difference between fractionated radiotherapy and high single doses. And Professor Frederick Wenz from Germany has done a lot of work on this, how the biology, radiobiology is very different and doesn't depend on linear quadratic equation at all. So the high single doses also has another immunological effects as well. Radiotherapy can be immunologically suppressive, but high single doses can be stimulating And what might be happening is here, a high single dose, it is used in the brain. In fact, in the brain for glioblastoma, what they have found is with this technology, when they give glioblastoma radiotherapy in one place, a glioblastoma far away in the brain seems to reduce. So there seems to be other factors that are going on other than the actual physical dose. That
something like abscopal effect.
Abscopal
There was an issue about the margins, because some of the guidelines say that a 2 millimeter margin for invasive cancer and a 3 millimeter margin for in situ cancers. So now maybe we can have Dr. Gautam Sharan, what do you say? Do you think the new definition of margins in terms of no ink on tumor is acceptable for APBI?
No, sir, no.
You still want 2 to 3 millimeters of margin should be there.
Dr. Gautam Sharan, I think his screen is frozen. So meanwhile, oh, Dr. Gautam, yeah.
Yes. So what I was telling, sir, is it's not the, I'm sorry. I think my internet connection, am I audible?
Yeah,
Yes,
you're
yes.
audible now.
So I think at least a 2 millimeter margin should be achieved before attempting APBI. And
Dr. Punita?
in which we do the whole breast radiation in which no tumor on ink is good enough.
Dr. Punita, no tumor on ink or 2 millimeters
2
for
millimeters.
APBI?
Now the verdict is out, 2 millimeters.
Dr. Vaidya, you would?
Well, in the trial, it was 1 millimeter, but I don't believe that is really, if the current status of surgical margin enough is ink on margin, that is fine. The dose given in a single dose is huge, really. So I am not worried about any change in the margin definition. And
So
the other point I wanted to say here was this question about superficial lesions. So somebody has asked a question about superficial lesions. Superficial lesions is not a problem. When the lesion is superficial, in fact, it is quite easy, because normally you would take away an ellipse of skin. So imagine the lesion is superficial over there. You've taken away an ellipse of skin. So you have very nice tissue on all pillars on all sides to go around the applicator to give the radiation to the tissues immediately beyond the tumor. Because what is more superficial is air. It's all out.
No, but how about the skin doses?
No, the skin is not, there is no skin anymore.
No, but you still close it, no?
Yeah, but you don't close it completely. No, you don't close it completely. So what you do is applicator is put in.
Yeah,
that is the pillar. This goes around. You go a few millimeters below the skin. So skin doesn't get any dose. Yeah, the skin, what is most superficial, is already taken out by the surgeon.
But in that case, isn't some of the target area not exposed to radiation? If you keep the skin away from the applicator.
No, not skin. You only keep the dermis from the applicator. So you make sure that the skin, so if it is like this, suppose that is the tumor. Okay, tumor is here. You've taken away this place where it was closest to the skin.
Okay.
So this part, which is what is now the tumor bed, that gets the radiation because that's where it comes.
Okay.
And the skin, which is 1 centimeter away, remains away.
Dr. Yadav, you wanted to say something?
Yeah, as far as toxicities are concerned, we know that it depends on the volume of radiation also.
Yes.
With PBI or target, the volume of radiation is very less.
Yes.
So the tolerance of the organ will be good in that case.
Indeed.
My question to Dr. Jain is and to our other radiotherapy colleague would be how comfortable they will be using target treatment without pathology report.
Yes. It's
very
we do operations without pathology report as surgeons.
No, but giving radiation, I think it's.
I see what you mean.
Difficult.
It's an important point which worries many radiation oncologists because they're not used to doing it. Now, what happens here is you have the facility to add whole breast if you need to, because the good news is that we know it doesn't cause more toxicity. So if you're given the radiotherapy during surgery and if you find postoperatively on core biopsy, it is a tumor that you're happy with, and then you find extensive lymphovascular invasion, multiple positive nodes, and you are uncomfortable that target is not enough, then you can add whole breast. And it doesn't change anything because in 8 out of 10 people, it will be fine. And the targeted trial allowed those patients, and toxicity in those patients actually is not much worse. So overall, the toxicity is lower. Toxicity, if you give this, there is a bit of slightly more fibrosis, but it is no different from a boost patient who gets external beam boost.
But like 20% of your patient has retrospectively received whole breast radiation.
Not
So 20%, if you
retrospectively.
see, it will be a huge number.
No. What I mean is, out of 10 patients who get it, out of 5 patients who get target, one of them in the trial received whole breast. That was the protocol. Now, in real life, when we are choosing patients, because in those days we didn't do ultrasound scan of the axilla, and we didn't do many times were not core biopsies. Now we have core biopsy, full analysis available. So the chances of receiving this external beam is going to be less than 20%.
One of the biggest limitation of the equipment is it will be dedicated for radiation only, breast radiation only. So for radiotherapy point of view,
you can use it at other sites also.
It is used for the brain. No, it is used for brain. It is used for spine. It is used for rectum. So it is, and for head and neck cancers as well.
Yes.
I'm not a salesman, but it is used in all other sites.
It is being used in all other sites.
Dr. Harish, I would like to ask one question from you. That suppose the patient has undergone mammoplasty or that oncoplasty, and the patient otherwise is suitable for PBI. So how you are going to deal with that patient, and how will you localize it for PBI?
For oncoplasty is not a contraindication for a PBI, and there are even guidelines which tell that you can do it. And what you have to do is you have to use clips, insert the clips before doing the rotation of the tissue. And there are guidelines telling about the margins that you have to take. You have to take the clipped area, and you CTV, after CTV you have to take an extra PTV even for brachytherapy when you are using the oncoplasty. Only thing is that you have to add the PTV margins, and you are allowed to do APBI in oncoplasty cases also.
But are you comfortable?
Guidelines for,
because the volume then increases when you are adding 1 to 2 centimeters of PTV into this thing, and there is a rotation, so much of rotation of the tissue which is happening.
But still, you are restricting the volume from the whole breast. You are decreasing the volume of radiation. So the results will be better. Only thing is that to avoid the uncertainties, the clips has to be inserted before rotation. That will be more important.
I think Dr. Vinita wants to say something.
I would be very uncomfortable to do. Partial breast radiation after oncoplasty, especially in the post-operative setting, because the uncertainty of localization of the tumor bed certainly increases manifold. If I have to do an intraoperative brachytherapy, then I'm fine, but not with the post-operative. So one small point I wanted to make. I was rethinking about the doses that we were talking, Conventionally, as a radiation oncologist, we've been taught microscopic disease. You need something like 45 gray, 50 gray. Nothing less than that is sufficient. But a second thought is that 20 gray single fraction actually is equal to 40 to 50 gray. Radiobiologically.
Yes.
Indeed.
Yeah, and that kind of dose is going to the surface. Another thing is that while we are saying that at 1 centimeter, the dose reduces to 5 to 6 gray is what Dr. Jain said. But how about 5 millimeter from the surface of the cavity? That is still getting a higher dose.
Yes.
So, and now since we have, earlier I was also not very convinced about it. But as a second thought, I think now since we have longer term results also available, I think it is the correct way.
I think, Dr. Vinita, I am not a radiation oncologist, but there is a progressive fall from the surface to depth.
Correct.
So that is somewhat like you are assuming that the requirement of the dose is progressively reducing, say, from 0 to 1 to. So that is something which is difficult to sort of accept. For interstitial brachy and external beam, you have a relatively uniform dose distribution. So that is a difference between the two approaches.
No, sir. Suppose I'm doing external beam radiation therapy, then also I give extra dose to the tumor bed. So there is actually a gradient. There is always a gradient.
No, that gradient is different. But when you do APBI by external, so whatever the volume is, you try to achieve a uniform dose within the volume. That's not a graded dose.
Correct. But no amount of external beam partial breast radiation can match either intraoperative radiation therapy and interstitial.
So I think as Dr. Jain said, the proof of the pudding is in the eating. Dr. Jain, if you have APBI, Dr. Bhuti, I'll just come to you. If you have, say, oncoplastic surgery, so do you deliver the radiation before the surgeon is doing the oncoplastic component?
Well, I'm the surgeon. So
Yeah. Oh, sorry. Yeah.
So what I would do is I would give the radiotherapy to the correct tumor bed, then do the remodeling, and so that the radiotherapy is given to the correct target tissues.
Correct target. So I think that is an advantage of intraoperative.
We have got data published from Germany where patients with were given intraoperative boost for locally advanced cancers with oncoplastic surgery, where what is strange was there was improvement in survival. And this is what we're going to test in the Target B trial. So Target B trial will test whether giving radiotherapy during surgery as a tumor bed boost, everybody gets whole breast radiotherapy.
Okay.
See whether this has an abscopal beneficial effect. It sounds far-fetched, heretic, but may be true.
Okay. Dr.
But then
Yadav
how
and
will you
Dr.
sequence your chemotherapy if you're doing intraoperative?
So what happens is the IORT is given to the patients randomized to have IORT. Patients randomized, and they receive their chemotherapy after surgery. So the most important part of radiotherapy is finished. They receive their whole breast after chemotherapy.
Okay.
And the patients who get chemotherapy on the external beam arm get their whole radiotherapy after chemotherapy.
Dr. Yadav, please.
So like when we were talking about the margin for APBI, we talked about 2 millimeters. But when we talk about recurrences within the same quadrant, we talk like 1.5 to 2 centimeters, 60 to 70% of the recurrences, they occur within that area.
Yeah.
So are these statements are not contradictory?
It's a very interesting point. Well, we don't know how many of these recurrences are tumor cells left behind, how many of them are new cancers, because we know that around the primary tumor, there is higher aromatase activity in the tumor tissue, in the breast tissue. So there may be other multifocal cells which are growing better around the tumor. So that's why they may be appearing 1 centimeter away, and that you can't be accurate about how far it is from the original tumor bed. So yes, we found that, and this is also coming out, that the recurrences after EBRT seem to have bad prognosis, but not after IORT. So the number of deaths actually are not more, distant disease are not more. So
I think
interesting this.
Dr. Sharan and Dr. Punita. So first Dr. Sharan, then Dr. Punita, please.
Yes. So my question is to Dr. Vaidya, straightforward, that it is radiobiologically justified to give boost and then consider chemotherapy, or that means giving a long gap between the boost and the actual whole breast irradiation.
Yeah. So this is a point which we have thought of very carefully. What it is this is not a single, this is not one of the multiple fractions of radiation. It's a large single fraction, and its biology is not something that is similar to one of the fractions of fractionated radiotherapy. To put it more clearly, it's not necessary to explain this to you, but for those who are not radiation oncologists, when you give multiple fractions, you are trying to kill cancer cells while leaving normal cells behind. And between fractions, they can multiply. So you're giving them again and again and again, just like chemotherapy is done with cycles, so as to kill cancer cells. Whereas, and if you give a gap, then you make the cells multiply. That's the point.
So as I understand that your boost acts as an stereotaxy, and then you go on for routine conventional radiation.
Single dose, yes.
Does that mean that I can plan my stereotactic boost the same way after many months of whole breast irradiation, or vice versa?
I don't know. In the trial, I see the point, and we will find out in the trial whether that gap makes a difference or not. But as far as we believe, it is a single dose, which is a large single dose, not like one of the fractions.
Thank you very much, sir.
Dr. Punita, you wanted to?
Yeah, just an extension of what Dr. Vinita was saying, and Buddhi also mentioned. I mean, one just wonders what 6 gray at 1 centimeter is actually doing, because it's like it's not for microscopic disease. It is 20 gray on the surface, one understands, but 6 gray at 1 centimeter, what it is doing, could we have done without it only in the first place? I mean, was this a candidate with? So that's what I am wondering.
That's a very important point. And what I want to say is, it is not the 6 gray at 1 centimeter. We say 6 gray at 1 centimeter because it's easy to prescribe, but it is really the 20 gray at 5 at the surface. That is the dose, and up to 5, as Dr. Vinita just said, is at half a centimeter, which is where we can expect microscopic tumor to be left behind. The dose is quite high, and biologically, that dose is similar.
The tumor has not decided that it will be only up till 5 millimeter. It would be, I mean, the kind of tumors you are proposing to sort of expand your horizons on. you may as well. There's ample literature which says that there would be tumor cells at 1 centimeter or
possibly. But if you are saying about talking about no radiotherapy, and that's an important point. So these are the trials without any radiotherapy. And you can see actually with no radiotherapy, you do have quite a high local recurrence, much higher local recurrence rate than what we have seen in the Target A trial. This is despite extremely good prognosis cancers. So I think Target is doing something. And I don't think there is any doubt about that. That's all I'm trying to say.
Okay. Dr. Dinesh, can we take?
Yeah,
Dr. Buddhi wanted to say something.
You must have certain, my question to Dr. Jain, you must have certain recurrences at the primary site, then patient underwent re-excision or maybe mastectomy. So what kind of pathological changes were there in the primary site with such a high dose? I think you should know that.
Interesting. We have been looking at it. A lot of it was necrosis. So we did one study in which we did this in patients who could not have surgery, where we only inserted the bare probe without the applicator under local anesthetic. And we did MRI scans. We found a lot of, we did biopsies, lot of apoptosis, necrosis, and complete loss of vascularity. So within 6 days, the MRI found no vascularity. So it seems to make a difference in the local, not only the tumor cells, the fluid, but the architecture in a very small area, so that toxicity is less. And because it is given from within the breast, it seems to be effective. So it is, what you're saying is very interesting. And other important point you make here is if patients have received external beam radiotherapy in the past or have received IORT in the past, they get a recurrence in other parts of the breast, they have the option of having another breast conservation. And we have published series about these such patients. They seem to have good results. So then the patient can save the breast. Otherwise, standard treatment is a mastectomy if you get a recurrence after breast conservation.
Any comments about the pre-operative use of partial breast irradiation? Anyone has any experience with that or any concept about it?
I hope it comes out soon. Dr. Goyal is not nodding his head.
I think it will be a good thing because the localization issues which are there can be sort of done away with.
Yeah.
That is something we should really see.
And
Is some work I think
sequencing
is going on, and some sequencing also would be there. Dr. Harish, are you thinking about pre-operative?
In fact, there is literature of pre-operative APBI by external beam radiotherapy. In fact, I done one patient of interstitial pre-op APBI. That's out of, just patient was interested in doing that and the surgeon was ready. Only one case when I done. And we had seen that the necrosis, there was residual tumor after that. That was very early tumor. So ultrasound guided needle was inserted. And I was a little concerned about tumor seedling outside there because of the needle insertion and all. But somehow the patient is doing fine till now. Now it is 2 years now. Not regularly done. And another thing I would like to just mention about the Dr. Buddhi's comment about the margins, the histopathology. When we are doing interstitial APBI peroperatively, what we do is that we do the simulation on after 48 hours, and then we start the treatment on day 3. We give 4 fractions of radiation. By the time we have the histopathology report available, if there are any adverse features, we consider the patient for external beam radiotherapy after 3 weeks from that time, and we take it as a boost. That is one way of we do routinely for doing the histopathology.
We also do the same thing.
Yeah, that's the safe way of doing it.
Okay. Can I ask something here for Dr. Harish and Dr. Punita? So you have probably used both interstitial and external beam. So do you have a preference in terms of what you would like to use on a long-term basis?
Actually, we will be interested in doing the interstitial one. In fact, I did one thesis study on one of my candidate comparing the interstitial versus external beam APBI, and the results were all the initial results were all comparable. The long-term results are not that, and the number of patients was very less, 15 patients. So we cannot generalize the things. Only more of patient preference and the radiation oncologist preference. That's what I feel.
Can I say one thing?
Yeah,
sure.
Just when I came to London from Tata Hospital, one of the reasons for doing Target was because I was seeing such patients in Bombay. It is real. And well, my hope was that if we show this works, it will be
Yes.
used all over India.
Yeah.
And I do hope people give some sort of a consideration for trying to see if it can be used in India.
Yes, definitely.
It is there, and I know there can be a lot of arguments for and against and so on and so forth, but please do consider it in that way. That's all I'm saying.
Yeah, absolutely. Dr. Panita?
Yeah, so your question regarding between interstitial and external beam radiotherapy for partial breast, see, the longest data is the most robust evidence is with interstitial. That's one thing. So one would prefer, but external beam offers you ease of administration. I think we are inherently becoming more and more lazy and opting for EBRT. But the real issue with interstitial that we have faced in our experiences, that you like what Buddhi also mentioned, and if you look at Ashwini's work also in interstitial APBI, see, you do interstitial per-operatively, and then you wait for the pathology report. Now, it's pathologists don't work according to you. And so waiting, it sometimes becomes very tedious, because the report comes, and whether you go the boost way or APBI way becomes an issue. And that is the reason why sometimes one opts for external beam APBI rather than per-operative partial breast or the boost.
So when you do external, do you schedule it before chemotherapy, or if a patient has to have chemotherapy? Dr. Panita? Dr. Panita, could you get my question?
Your voice cracked in between.
Yeah, suppose a patient needs chemotherapy also, so, and you are doing external beam-based treatment. So would you schedule it after chemo or before chemo?
I would prefer to schedule it before chemo, because after chemo, again, there are a lot of changes that would have occurred in the cavity. So we would prefer to use it before chemo.
And your medical oncologist accept that?
Not always. I'm talking.
We will be able to finish it within 5 days.
Okay. And Dr. Buddhi?
So can I?
As far as brachytherapy is concerned, I think as Dr. Jayant Vaidya showed that putting a lot of needles, I think there is definitely some fear of scarring. Because our boss, Dr. Professor S.S. Sharma, he used to do a lot of brachytherapy. So I am following up those patients. Scarring is cosmesis is not good with the brachytherapy.
Okay.
Maybe a good technique, but cosmesis is not good. And a lot of patients, they complain of pain at the needle area. So that is another issue.
I mean, I think you're so right in saying that. Imagine patients, you should show the patients these photos. This is what happens when people get brachytherapy. And although there is a conception that brachytherapy has the longest amount of follow-up, but this Budapest trial was the first randomized trial about it. There were 130 patients in each arm of the trial, and it is tiny compared to other trials of partial breast.
Yes.
And the other Jack-Estro trial has only 5-year follow-up. So it is not that brachytherapy has the longest and most amount of data available.
Okay.
Yeah, that's all.
Can I make a point here? Yes.
Yeah.
So I think I disagree with Dr. Jayant's comment here, because I know the wires would leave some amount of scarring, but over the years we've learned how to save the skin so that the skin should not get the radiation dose and the scars heal well. So I have to anytime choose between external beam radiation therapy versus interstitial or jet. I would always prefer interventive procedure, because apart from cosmesis, what also does to the lung and the heart.
Yeah, you're right.
Which is least with any kind of intra procedure.
Yeah. So what you're saying, I didn't want to specify, but I wasn't talking about the cosmesis. That was said by my colleague. But what I was talking about is the fact that concept that brachytherapy has the largest amount of data. That's all.
Dr. Jayant, there is a very important
Another
question
small
here.
point.
Yeah.
Can target be used for pregnant women?
Right. So that this was a question we have been asked, and we almost arranged for everything to be done. Our physicians were comfortable with that as long as it was second trimester of pregnancy. They said they could shield the abdomen pretty well, and that it was possible. In the end, it didn't happen because something else came wrong. We didn't actually treat the patients. What you have to remember is our criteria are 45 and over. So somebody who is 45 and over and has a
Oh,
pregnancy, it is likely to be a precious pregnancy, and then we would
yeah,
not
I know.
be comfortable.
You don't want to do that.
It was not a
So,
contraindication, but I
yeah,
see. Yeah.
it's a
Can I
small
ask
point.
two questions
Yes.
to
Yeah,
Dr.
Dr.
Vaidya?
Vaishali.
Yeah.
Yeah.
Yeah,
Dr. Jayant, as a surgeon, administering such high doses in the operative bed, does it lead to any large number of wound breakdowns, especially if you're doing oncoplasty? Have you
Yes.
seen?
So
Have you noticed?
okay, no, we haven't. So this is what we first, when we did the first 25 patients, they also got external beam, so they had a large dose, and we didn't have a problem. Our third patient had a problem. That's all the problem we had, because the skin was almost onto the applicator. She developed a small hole there, and it took some time to heal. But there has not been wound problems at all. This has been reported in the randomized trial. The chance of needing an aspiration was increased from 0.8% to 2%. So there was a very slight increase in the need for aspiration, but 98% patients didn't need it. And there were no wound healing problems at all, because you protect the skin when you give the radiation. It is, as a surgeon, you'll find it is as neat and nice to do as you do a lumpectomy, because
And
you're giving radiation to the right place.
what about fat necrosis? Have you seen any
No, no, no.
increased incidence?
No,
No,
we don't
not.
find fat necrosis to
Okay.
be higher. It is there in the Elliott trial, where a large amount of tissue received the uniform dose as per what they wanted to do, to a large amount of tissue where they did find fat necrosis. But with target, the volume of tissue that receives is the huge dose is small, and we haven't found fat necrosis to be a problem.
Okay.
Postoperative mammograms are also not a problem.
All right, thank you. There was one more question regarding the eligibility. In case if when we say that multicentricity is a contraindication for APBI or for target, would you do MRI for all the patients before you plan IORT or
Very, very
APBI?
important question. In the Target A trial, MRI was not a requirement. And despite the trial running from 2000 to 2012, and most patients in later years, only 5.6% patients had MRI. Okay, so all those other patients who didn't have MRI must have had some extra lesions found on MRI. It didn't make a difference to us. So multicentricity, what we are trying to prove in Target A trial, that the other cancer foci actually don't matter. And other quadrant recurrences were no different between the two arms. Other important point is, if you find two cancers very close to each other, because we find them more often these days with better tomography and so on and so forth, if we are going to excise them in one lesion and no other tumors are present, that is fine. I don't think that's a contraindication.
So I think the biology of breast cancer is an enigma from NSABP B04 to Z11 trials. We know that there are tumor foci which do not become manifest clinically. So probably something at play here also.
Exactly. Yeah.
Yeah, Dr. Dinesh, anything
I
else?
think we had a very nice discussion. Any other questions or comments from anyone else? In fact, having this facility target is not available at most of the centers in India, only to have it. And also, if we look at the percentage of patients who are fitting into this PBI, is 10% or maybe less than 10% in our current situation. Also, maybe we are not very much thinking about a possibility of these patients. And the idea of this webinar was to bring a focus on to the PBI, that more and more patients should be thought that they can be candidate for PBI. So with that, whatever technology we are using, we are at least saving the dose going to their lung and to their heart, whether it is an external IMRT or brachy or target. So, and we had, and I would welcome any comments from any other person. Yeah, Dr. Vaidya,
Dr. SVS Dev, I don't know whether he has joined us or not, from All India Institute of Medical Sciences. From what I understand it, they're going to install a machine in All India Institute of Medical Sciences.
I think I've heard that there are going to be two machines ordered, one for AIIMS and one for the NCI campus. So I think that will be a good boost to the whole concept. And while we all definitely are for target, but Dr. Vedya, you also realize that in India we have everything from cobalt to top-end IGRT machines and CyberKnives and all, and
The
protons.
proton
So
therapy also.
I think there is space for everything, and to actually increase the reach, we have to utilize all the possible approaches. So what I would request is maybe all the panelists to give a 1 minute sort of take-home message for all the audience, what you would like to say. Dr. Harish, you can start.
Yeah. I feel that selecting out the right patients for the APBI versus whole breast radiation is the most important thing. And whatever the technique, it all depends on your expertise. And in fact, since we are more comfortable with the interstitial and external beam APBI, we are doing that. And we don't have other techniques as of now. And that's all.
Dr. Vinita?
I think the partial breast radiation is here to stay, and it has been proved to be safe in suitably selected patients. What we need to educate surgeons, or we need to remind surgeons.
I think it is a very critical point.
See, Dr. Vaidya could do this because he himself was operating upon those patients. So I think Dr. Goyal needs to invite more of surgical oncologists for these kind of seminars. We radiation oncologists are in for partial breast radiation.
No, I agree. We invited all of them, but as I said, unfortunately, there were so many competing events today. But I believe the event would be available on YouTube, so we'll send the link to everybody.
No, there are few surgeons in the audience. There are, in fact, many surgeons in the audience.
Yeah. Dr. Yadav?
I think along with choosing the right kind of patient, choosing right kind of dose and the technique is also of importance, because with hypofractionation, I think if a gray or 2 gray may matter, because that can cause a lot of difference. We have seen in many trials. So I think the right kind of dose and technique is also important.
Okay, Dr. Punita?
Yeah, it's actually the same. Basically, this patient selection is all important, and it should remain all important. And yes, I mean, target is there, but sorry, Dr. Vaidya, one would deal with it with little more skepticism, because everything about it is different. So one needs to look into it. Our experience has greatly been with interstitial and EBRT, and yes, target is something that one can look about it.
Is Dr. Gautam still there, or has he left? So let me ask
Can I say something? Just a last bit.
Yeah.
Only thing to say is this: while we are all talking about what we have experience with, what is available, and what should be how we should select, what is more and more important today is what is that patients want to prefer, and patients should be given whatever choices that are available. And if they're available somewhere else, some patients may want to choose to go there. But if you find that your patients want to have, what I suggest is, if you can simply give patients the slides which I showed, these are the different options, which one do you want? And if you find that 80% of your patients, or large proportion of your patients, want a particular treatment, and they will vote with their feet, and I think it is our duty to listen to them. That is
absolutely.
They ask the patient, what is it that you prefer? Of course,
I agree.
I'm biased, because people will say, I want my operation.
No. Can I just ask the 4 of the panelists, from tomorrow, would any of you be willing to treat a node positive patient with APBI? Yes or no, Dr. Harish?
No, I mean, node positive, not taking.
Dr. Yadav?
So it is not only the node, there are other criteria like age of the patient, then grade, PR status. You have to consider. If the patient is elderly, I will be comfortable.
So a 60-year patient, 60-year, 3 centimeter tumor, ER positive, node positive.
Yes, I will.
You will treat. Dr. Vinita?
So I'm with Dr. Buddhi Yadav.
Okay, so you will take. And Dr. Punita?
No, I will treat the node.
You will. So it's a split house. Let us say that the indications are expanding, and probably with more and more experience with node positive patients coming in, we probably would have a consensus this way or that way. So I think that should be it for the panel discussion. Is there any major question left, Dr. Vaishali, from the?
No, I think we have covered almost all of them. And Dr. Jayant and other faculty members also answered in between. So we've covered most of them.
Sure.
Just one
Dr.
point,
Dinesh?
Vaishali.
Yeah.
I am a little uncomfortable about still doing partial breast radiation for HER2 new positive breast cancers. So any comments from Dr. Vaidya? I mean, I'm okay with triple negative. But
Yeah.
when it is a
So
HER2 new positive subset, then I'm a
So
little
HER2
uncomfortable.
positive would be patients who in olden days would be at high risk of local recurrence. Now, almost all of them get anti-HER2 therapy. So I think they are back converted to non-HER2. Now, HER2 therapy was not always given to target A patients, and HER2 didn't make a difference in the outcome at all. And 15% patients were HER2 positive, which is similar to what you would get in normal population. So it was not selected to be HER2 negative or anything that way. So HER2 doesn't come in the picture. Yeah.
I think this brings one more question here. Nowadays, there is a lot of trend to use neoadjuvant therapy when it is triple negative or HER2 positive, even in a 2 or a 3 centimeter tumor. So, Dr. Vaidya, you get a pathological CR. What do you do? Do you do APBI?
I don't give. You see, if you have not read, I have published a paper on neoadjuvant chemotherapy. How, in fact, it has no
I've
benefit
read
to
that
patients.
paper.
Yeah, we have read that.
So I'm skeptical. I mean, there is evidence. I don't have to be skeptical. It's not my belief. It's the evidence that it actually doesn't benefit patients.
But the
So if
practice
it's
is
being given to
changing.
patients, all those patients are eligible to target B patients.
Yes, yes. Okay.
Yeah.
Yeah, Dr. Buddhi, you wanted to say something.
Yeah, about HER2 patients, I think HER2 patients, they tend to have better response. If you see the patients on HER2, if you treat them with whole breast radiation, reaction is very brisk. So that give you an indirect indication that if the reaction outside is quite brisk, so inside it will be a very good response. And we have seen this with the whole brain RT or with the SRS in patients who have brain metastases. They tend to have necrosis when they are treated with the SRS during or after HER2 therapy.
Yeah.
So I think it is a very good predictor for response.
Okay, thank you. I think Dr. Dinesh, you should sum up and.
Yeah, I think it was a very fruitful, useful discussion, lot of insight straight away coming from Dr. Vaidya and within panel of experts. And almost all aspects of the partial breast irradiation, they have been covered. And it was very enlightening. And I will thank all the experts and the panelists for this. And this is going to change the mindset of all the attendees, that we will be looking more for the eligible candidates who are more suitable for partial breast irradiation than what I think it was till now. Dr. Goel.
I think you said it all. Thanks a lot. And thank you, Dr. Vaidya, for really taking time out from your busy schedule. And Dr. Punita, Dr. Harish, Dr. Buddhi, Dr. Vinita, and Dr. Gautam, who's left, and all the people in the audience. So I hope that it brings out a change in mindset and thinking about APBI as a possibility every time we see a breast cancer patient. Thank you.
Thank you very much. Thank you very much.
Thank you.
Thank you for making me part of this discussion. Thank you all.
Thank you.
Thank you. Thanks a lot.
Bye-bye.